Thank you for coming to the National Press Club on what I think for a lot of us was a very busy day with the annual release of the budget request earlier this afternoon. Welcome journalists, welcome National Press Club members, and welcome to our club president, Mike Friedman, who will be joining us in a moment. And welcome to everybody in our live stream audience. You will have the opportunity to submit questions later during the Q&A portion of the event. My name is Rachel Oswald. In my day job, I cover foreign policy for CQ Roll Call on Capitol Hill. Tonight, I'm here in my capacity as chair of the professional development team at the Journalism Institute here at the Press Club, which has organized tonight's event. And for those of you here in Washington, we invite you to return here tomorrow at 10 a.m. at the Press Club, where we will be having a headliners event featuring Dr. Ann Schuchak, the Principal Deputy Director of the Centers for Disease Control and Prevention. She will provide an update on the administration's response to the coronavirus. And with that, I think I'll introduce our panelists, who combined have over 70 years experience working in public health and are here tonight to help us, the press, figure out how we can proactively and responsibly cover this novel coronavirus, which is still ramping up, and we do not yet know the full scope of its impact. First, we have Dr. Nancy Messonnier, who comes to us with 25 years experience in public health and has been the main spokesperson explaining to the press and the public the U.S. government's response to the new coronavirus. Dr. Messonnier currently serves as director of the CDC's National Center for Immunization and Respiratory Diseases, where she prior served as deputy director from 2014 to 2016. Thank you for that. Oh. And I thought my voice carried. Prior to that, Dr. Nancy Messonnier served from 2007 to 2012 as the head of the Meningitis and Vaccine Preventable Diseases branch of the CDC's Division of Bacterial Diseases. Next, we have Dr. Anne Marie Pettis, a registered nurse with over 30 years experience as an infection preventionist. Anne Marie is the president-elect of APIC, the Association for Professionals in Infection Control and Epidemiology. She's also the director of infection prevention for University of Rochester Medicine in Rochester, New York. During the SARS epidemic in 2003, Anne Marie worked as a volunteer with health professionals in Ontario to contain the outbreak. Anne Marie was co-chair and chair of the Western New York Infection Control Organization and a member of the New York State Advisory Healthcare Associated Infection Committee. And then we have Amanda McClellan, also another registered nurse. Amanda has over 15 years experience in international public health management. She is the senior vice president of the Prevent Epidemics team at Resolve to Save Lives, where she leads the organization's planning around prioritizing which countries are most in need of technical assistance in the event of an epidemic. Amanda is a risk communications expert and previously worked as Global Emergency Health Advisor for the International Federation of Red Cross Red Crescent, where she helped focus on epidemic control, the handling of mass casualties in underdeveloped nations, and coordinating disease prevention and response operations. And she also helped coordinate the international response to the 2014 Ebola crisis. And finally, we have tonight Andrew Siddons, our moderator, and my esteemed coworker. Andrew has been a health reporter for CQ Roll Call on Capitol Hill since 2015. He covers the CDC, NIH, FDA, and has been leading our newsroom's coverage of the novel coronavirus. Andrew has been working as a journalist in Washington for over a decade and also has a master's in public health from George Washington University. So I'll leave it to you, Andrew. Thank you.
Thanks, Rachel. All right, can everybody hear me? I want to thank our panelists and for everybody here and everybody watching live. First, I want to note that Dr. Messonnier has done, by my count, at least 10 press calls or availabilities since this started, and I appreciate that, and I think on behalf of the press, we appreciate the accessibility that CDC has provided, so thank you. I was wondering if you could first provide us the latest on what the CDC knows and doesn't know about the virus, including things that would be important for reporters to know about the symptoms, how it spreads, and what people should know about their risk.
Sure. Let me start, and we see how long this goes, because I could talk for hours.
Okay.
December 31st was the first time that China reported an outbreak of respiratory diseases. It was first reported as associated with a live animal seafood market in the city of Wuhan. Within 2 weeks, they had identified it as being due to a new virus, and it's a class of viruses called coronavirus, thus the name novel coronavirus outbreak. To date, there have been 40,000 cases of this novel coronavirus reported from China. 30,000 of them are from Hubei province and the rest from elsewhere in China. Among the 40,000 cases, there have been a little more than 900 deaths, and this past weekend, the first death in an American was reported in Hubei, somebody who is older and with underlying illnesses, which is characteristic of the severity that they've seen. Generally, it seems to be worse in people who are older with underlying illnesses. 27 or so other locations have reported cases of novel coronavirus outside of China, including, as of this morning, 12 cases from the United States. The cases in the United States, 10 of them have had direct contact themselves with travel from Wuhan, but the other 2 cases in the US are very close contacts of a travel-associated case. And that's also characteristic of the cases we've seen in other countries. The majority of the cases are in people who have traveled themselves or have been in close contact. But we are definitely seeing person-to-person spread of this virus. In China, it's clear that there's community spread, and there is some evidence in some places so far outside of China that there is some seeding of the community. The symptoms of it are respiratory viral symptoms, and you can equate that to lots of other viral respiratory diseases that are more common. Fever, cough, shortness of breath, as you can imagine, making it somewhat difficult to differentiate early. In the United States right now, we continue to believe that the immediate risk is low because we've been very aggressive with our control efforts, and the cases in the US, again, are in people who have either traveled directly to Wuhan or have been in contact with somebody who has. The aggressive efforts started, I think, by the Chinese government closing down the city of Wuhan around January 24th or so, effectively shutting off the community, also shutting the airport. It is a major hub airport. That was followed in February 2nd or so with major efforts by the US to decrease people coming into the United States, also from China. And so you can dramatically see the potential for transmission into the US at least slowing down. And our hope is that we can slow it down enough for us to be able to pause and work through a lot of what we need to understand about this virus in order to be able to better control it.
I want to go to Anne-Marie and ask, what should reporters know about what's happening within the healthcare system and at hospitals as people prepare for this outbreak? And does it differ much from what they're doing already on a day-to-day basis?
Yeah, and let me just say it's a real honor to be here. And so I'm an infection preventionist, and there are professionals like myself all over the country in all sorts of different healthcare facilities. And right now, all of us are very busy trying to prepare for this evolving situation. But we are professionals who have expertise in preventing infections in patients, in their families, in healthcare workers, and in the community, actually. And so we have that expertise, whether it be germs that we're used to seeing on a day-to-day basis causing infections, or if it's something more novel like this, or outbreak situations. And some of them that come to mind, of course, would be swine flu, measles, SARS, Ebola. So these are things that we are very used to dealing with, I would say. Not that you're ever ready for a pandemic or something that spreads throughout the globe, and hopefully that's not going to happen. But at any rate, this is not something that we're not planning for at all times, and helping our staff hopefully have sort of a constant readiness, if you will. So in terms of coronavirus specifically, right now, I would say that there's a couple different things that we're all working very hard at. One would be checking to see where we're at in terms of our supplies that would be needed for healthcare providers to protect themselves as well as patients. So that would be things like gloves, masks, gowns. So we're all very carefully checking where we're at with that. And as you probably know, several of the manufacturers are in China. So that is something that everybody is thinking about and how that might affect us down the road. So it's important that, that we look to see where we're at and that we educate the public about not using masks inappropriately at this point, or healthcare providers using them inappropriately. So the supply chain is very, very important right now. And then along with that, the personal protective equipment that I mentioned, the gloves, the gowns, the masks, and so forth, we are trying to retrain and remind our healthcare force of what we went through during Ebola in particular and SARS prior to that, about the importance of putting on the equipment correctly, and just as important, sometimes more importantly, taking it off correctly. We know that when SARS was a situation, some of the healthcare providers that were infected from SARS, it happened as a result of them taking off the PPE incorrectly. So that's something that we're working with our healthcare providers and personnel, from the environmental service workers all the way up to the physicians and whatnot. So making sure the supply's there, making sure they know how to wear stuff correctly, reminding them of just the basic principles of infection prevention. As you know, we're in the middle of a very difficult flu season, and one of the most difficult ones in quite some time. And so, you know, constantly reminding people about the importance of respiratory hygiene, covering your cough, cleaning your hands. So that is all very important. And then the next thing besides supplies is we're looking at screening and reminding our staff of the importance of screening patients before they enter a facility or before they come to their doctor's office. And again, this is something that staff should be doing 24/7, 12 months a year, all the time. But as you can imagine, when you're not in the middle of a crisis, sometimes things start to slip a little bit. And so it's a very important time to remind them that we should be doing travel screening, and it can be as simple sometimes as coming from New York City. It doesn't necessarily, if I'm thinking measles now, it doesn't necessarily have to be coming from China. And so again, reminding them that travel is always an important thing to be checking with patients. We're even helping people understand that when they have patients call in for an appointment, that we're asking them, well, you're coming for what reasons? And if indeed they're giving us symptoms, whether it be a rash, fever, things like that, that we're trying to educate the patient before they get there, and perhaps seeing them outside of the physician's practice or the emergency department before they actually get in there. And so those are two important things then. So supplies, training, screening, and then last but always so important, and that is communication. And so all of us are very actively trying to stay abreast of the changes that are going on, and thank goodness for the CDC and our local health departments, our state health departments. So we as infection preventionists are trying very hard to stay in touch with the changes as they happen from day to day. And so communication, education, all of that is always important. But certainly this heightens everybody's awareness in terms of the importance.
Thank you. Let me go to Amanda and sort of pose a similar question, but on a more global scale. What do you think is important to understand about, what might be happening with the global response right now, and health ministries or health departments around the world?
Sure, I think everything that's just been said, except with no resources and no money and no technical specialists. And that's not to overstate it, but we specifically look at, we work a lot with Africa, but there is a a checklist that the World Health Organization has called the Joint External Evaluation. It helps us assess health systems and how ready they are for epidemics. And essentially every country in the world scores below the perfect score. Even America and Australia are at the top, but no one is fully prepared. And as Anne-Marie said, it's very hard to be prepared for all levels at a pandemic level. So some of the countries we work at, I was on the phone today with Zimbabwe. It's been in the media. They haven't been able to pay their doctors and nurses for several months, and the health system is collapsing there. So you're trying to prepare for a large-scale pandemic, potentially with no salaried staff. We're working in Nigeria at the moment. We have a team there. They have a large Lassa fever outbreak at the moment, a highly infectious viral hemorrhagic fever, 100 cases last week, more than 35 healthcare workers killed in the same epidemic last year because of failures in PPE. So as they try to prepare and resolve Lassa fever, they're also trying to prepare for coronavirus. We're finally getting close to maybe defeating Ebola in DRC, and they have 400,000 cases of measles with 6,000 deaths. So as big as this outbreak is, the measles outbreak in DRC is unprecedented. So many of the countries that we're supporting with and working with have weak underlying health systems and high risks of other outbreaks while they're then trying to manage this. And they have huge connections with China. So many of our counterparts in Africa, 1 million Chinese in Nigeria at the moment, heavy trade and travel links that are extremely important to fragile economies. And then a lack of diagnostics, so being able to detect those first cases. So we're really prioritizing, very similar to the same things that CDC and the US hospitals are prioritizing. Early detection, early response, early containment, but still trying to maintain a health system and control the other outbreaks that are ongoing.
Thank you. So since you said the word pandemic, one of our goals here was to, maybe help define some terms. I see a lot of reporters in the room who cover healthcare on a day-to-day basis, but maybe some of the people watching at home don't. So I'll throw this out to any of you, but maybe we can talk about the difference between an outbreak, an epidemic, and a pandemic.
Should I start? Yeah. I think that actually an outbreak and an epidemic are actually really similar in definition. I think people use the word outbreak to explain something smaller, and the word epidemic maybe something bigger, but technically they're actually both the same thing, and we at CDC pretty much use them interchangeably. What's different about a pandemic is that you have transmission of the epidemic in multiple geographic locations at once. So what's going on right now in China would definitely be defined as an epidemic, but the definition of a pandemic requires the same kind of transmission in another geographic location. So I think folks could argue this, but in general, the other part about this is that what really causes a pandemic is it's a new pathogen that the society hasn't seen before, which means that there's not any underlying immunity. Therefore, the whole population doesn't have any protection against it. And if that same pathogen spreads, again, in other geographic areas, that's a setup for a pandemic. Most people, when they use the word pandemic, they're thinking of something like influenza, because that is the prototypical disease that we have been preparing for which we've seen pandemics before, and for which we'll know we'll see one in the future.
Great. Maybe we can do a bit of a lightning round of some other terms. What is an R0?
Is that a me too? R0 is a word that's meant to convey the level of infectiousness of a pathogen. So it's the number of people that are infected by a patient who has the illness. So if the illness is only transmitted from one person to the next, that would be an R0 of 1. The R0 for coronavirus, the estimates are that it's somewhere in the 2 to 4 range, which means every person that has it infects somewhere between 2 and 4. Measles, since you brought it up, has one of the highest R0s. That's somewhere around 14 to 16, which is why people call it the most infectious of the pathogens. And you want your R0 to be below 1. That's how you know that you're getting the disease under control, that there are less people getting the infection than had it in the first place.
Incubation period.
Everybody.
Incubation period is just how we term it from when you're exposed to the germ or the virus or the bacteria to how long you start to show symptoms. And so it can range for different diseases. The current range, I think there was a new paper came out yesterday showing the average incubation period was around 3 days, but extending right out, one case report out to 24 days. So the incubation period, I think, is still to be confirmed. But it's something that's really important to us because it explains how long people go in terms of before they get sick, and it can affect how we report diseases and how many people are circulating that have been exposed to this disease before they're starting to present symptoms.
Maybe if I can add, this incubation period is a really big deal because it directly impacts how long we say people should be quarantined or how long people should stay home. So for this pathogen, the starting place is somewhere, it seems, around 2 days. The question is really, what's the longest incubation period? And it's hard with this disease because we don't fully understand the spectrum of illness. And the question really is, are people mostly transmitting when they have symptoms, or is it being transmitted from somebody who is mildly symptomatic or asymptomatic? Some of the other issues is that, this is happening really quickly, and the press is great. It's great that you guys cover these stories. Some of the reports that are coming out for some of these longer incubation periods aren't exactly yet in the peer-reviewed literature, and so sometimes it's hard for scientists to know what fact is versus what isn't well curated, especially if we know that, again, it starts as the starting place for calculation of incubation period is when someone's exposed. And so if, for example, whoever's doing the investigation didn't ask enough questions, they might have missed an exposure point. We're generally right now saying 2 to 14 days is what we think, but there are a team of scientists back at CDC pouring through the literature, trying to see if we can firm up those numbers, because it's directly impacting how we operationalize things here in the US as well as other countries.
And I think that's what's informed your policies on the quarantine period for people. But maybe you can explain the difference between quarantine and isolation.
So isolation generally is when somebody's sick. So tuberculosis patients are isolated so they don't transmit it. Quarantine is when you take somebody who's asymptomatic and you basically try to contain the disease, somebody who's asymptomatic but exposed, potentially at risk to their community, and you basically, quarantine is a legal order that you use to keep that person isolated so that they're not going to transmit the disease farther.
And Anne-Marie, maybe you can give a quick rundown of when we hear a lot about infection control or infection control protocols, like what exactly that might entail.
Mm-hmm. Well, again, it really depends on the particular germ that you're talking about. But there are certain basic things that should be done at all times to protect the healthcare worker as well as other patients in the hospital. So that would be something called standard precautions. So in other words, we use those precautions at all times with all patients. And really when that started was back with HIV, the AIDS epidemic. And so basically that means things like the hand hygiene that we use, the covering our coughs, just basic things that we, needle safety. Those are things that should be happening with all healthcare providers at all times with all patients. And then from there you move into isolation precautions. And again, that would really be dictated by the particular organism. So if it's going back to measles, for instance, since it is so infectious, that would require a particular type of mask, and they call them N95 masks, typically, or you can need those for tuberculosis as well, even though TB is not as infectious as, say, measles, but it's still considered what they call the airborne route. So that would be, we use the term transmission-based precautions versus standard precautions. And again, that is really dictated by the particular organism or germ that's causing that infection. So it really depends. And it's really the infection preventionist that helps to drive that in the hospital or the healthcare setting and does the education about that.
Okay. Amanda, I'm sure everybody listening knows that the World Health Organization is a thing, but maybe you could explain what it actually does in a situation like this, and what is important about its recommendations, or the fact if it does or does not declare that something is an emergency or not.
Okay, sure. So the World Health Organization was formed after World War II, really around the collaboration, there's lots of iterations of countries working together around diseases much earlier on. But the World Health Organization in its current form is made up of member states. It's part of the United Nations, and for that reason it's responsible to its member states, and that sometimes puts it into a difficult situation. You would have seen in the news today a lot of debate about whether they are too close to China and how they've been managing it, but it's very difficult when you are responsible to the countries that you're representing to find that balance. In relation to epidemics, there's a key piece of regulation that we use called the International Health Regulations, which is a non-binding agreement between countries to share information about epidemics and also help to manage trade and travel restrictions. But it's non-binding, so the WHO can make recommendations but can't necessarily enforce those. And so some of the discussion you will see is whether China shared information early enough and whether the international health regulation should be stronger to make that more mandatory. You know, it's a discussion that's been going on for some time, but it's very complicated to get countries to agree on these types of statutes. And so the IHR has been serving us relatively well for some time. And part of that is the ability of WHO to be able to declare a public health emergency of international consequence, or the FEC. This is an agreement by a group of experts that are formed around an outbreak to decide whether an outbreak poses international risk. And we hadn't used it so many times in the past. We've used it for polio. There was one declared for the West Africa Ebola crisis. One was declared very quickly after that for Zika. And then there were several discussions around whether it should be declared for the DRC Ebola outbreak, and one wasn't declared because people didn't feel that international spread was likely. That's not the case here. They had 2 meetings this time, and the first time was very early on in the outbreak. I think there was about 67 cases. They decided to wait for more information, and then the week after, they have declared an international emergency. This essentially allows WHO to make formal recommendations rather than informal. There's not actually such a big change, but it does give a lot of weight to governments. They do recognize that. They've recommended against travel restrictions, but some countries have chosen to put those in place. So WHO sets a normative body and tries to make recommendations based on the science in an unbiased way for all countries. After West Africa Ebola, there's been a shift in World Health Organization and a call for them to be more operational. So in the past, they didn't really have an operational arm. We got caught short during West Africa Ebola in terms of coordination and capacity on the ground, and they've definitely scaled that up. So it will be interesting to see as we move forward what their operational response will be. I think it's much harder in a pandemic than 3 or 4 direct countries. But they have traditionally been the normative body. They're starting to build an operational arm and are responding quite a lot since West Africa.
And Dr. Messonnier, could you please talk about what a public health emergency means in the U.S. context when Secretary Azar declared one a few weeks ago?
So Secretary Azar declared a public health emergency to draw attention to the issue in the United States and make it clear of the significance that he held it in. Just to be clear, he's been briefed about this outbreak since it was first identified in China. So this wasn't a dramatic change. It was a moment when he felt that it was appropriate to do it. It also does, there are some resources that declaration gives him and the CDC access to. And so that was also part of the reason to make that formal declaration.
And I think one other thing that it allowed for was for the Food and Drug Administration to begin going through the emergency use authorization for the diagnostic tests that CDC developed. So maybe we could segue to helping people understand just like what this test can
Sure.
and can't do.
So the Secretary can move towards an EUA without exactly that declaration, but it's a little bit complicated. So the declaration went beyond just that. But the idea is that there's a formal process for development of diagnostics in the United States. It's obviously really important for any diagnostic that is used for clinical care that we make sure that it's perfect. We wouldn't want to misdiagnose people. The EUA is a message from CDC and FDA that we're going to do a lot of things as quick as possible to make sure that the test is available more broadly. So it's remarkable to think about the fact that this outbreak was first identified by China at the end of December. A week later, when they identified it as a novel coronavirus, they posted the sequence in a formal way on a database that basically gives scientists around the world access to that genetic sequence. And it's something that we didn't have when we had SARS and MERS. Multiple countries, including the US, were then able to take that sequence and use it to identify cases. The first cases that were identified outside of China, for example, in Thailand, were because they had that sequence and they had patients who had respiratory illness and they were able to compare them. What we did in the US was take the genetic sequence and our laboratorians turned it into a RRT-PCR. It's basically a PCR assay, which is sort of a very prototypic way to do a diagnosis, developed by CDC laboratories, gone through all the appropriate quality control to make sure that the FDA is comfortable with it, and then we rapidly were able to start using it in the US to identify cases. It was very rapid, and that's remarkable because, again, diagnostics don't usually get developed that quickly. After we sort of had completed the package at CDC, then the FDA's EUA actually allows us to get it out to our state and local health department partners. So the EUA is the authorization that we need to allow us to circulate it. Right now, or last week, in order to do diagnosis, samples had to come to CDC. Once they arrived at CDC, it's basically taking about a day, but shipping specimens, especially from Hawaii, California, means that there's a significant delay of getting them on the plane and getting them there. And when you have patients sitting somewhere waiting to find out if they have this novel coronavirus, it's not the most operational thing. And so the signing of the EUA allowed us to get it out to our state and local health department partners as well as internationally. And that started shipping out last week. It takes the states a few days to themselves work with the kit to the point that they're allowed to use it clinically to make diagnosis, but hopefully that'll start happening this week.
You described it as a PCR assay, maybe without going too...
chain reaction. Oh my gosh.
Would there be an easy way for people trying to maybe describe something like that in print for a lay reader? Any suggestions for how to describe that?
Oh boy, yeah, somebody else, really. I guess what I would say is it's not an instant test like people think of with the strep test or a pregnancy test where you take a drop of something and you stick it on a plate and it gets a positive or negative. It's not that. That would be very helpful because it's an instant test. It is, you take a sample, you process it to extract the right genetic components, and then you put it in a big machine. I don't know, is that good?
Thank you. And one last sort of definitional question. Can any of you talk about the typical life cycle of an outbreak, where we might be in this one, and how it can be seen relative to other high-profile outbreaks like SARS, MERS, or Ebola, or even something more routine like seasonal flu?
Maybe I'll start, and I'm sure you guys will want to say something.
If you'll start, we'll jump in.
So genetically, when we first learned about this new virus and we looked at it, it looks like other coronaviruses. And so immediately where people's heads went was MERS and SARS. MERS and SARS are animal coronaviruses that moved to humans and caused outbreaks that many of us worked through. They were dramatic, and then they left pretty quickly. MERS still causes disease, mostly in the Middle East, and SARS, we haven't seen it since. So our initial concept of what we thought was going to happen was that it would be similar to those because genetically it was. But as time has progressed, the outbreak isn't behaving exactly like MERS and SARS in terms of the transmissibility and the patterns of it. And so we're really going back to make sure that we are appropriately humble as we think about new pathogens like this, that there are things that we expect, but we need to take the evidence and synthesize it and then understand this pathogen based on what it's doing. Where are we? I think that in the United States, the measures that we've taken, which were very aggressive, were an attempt to try to slow the thing down so that our healthcare industries and the rest of our partners could take the time that we needed to prepare for it. But it is spreading rapidly in China despite their aggressive measures to try to control it, and that's worrisome. And that's why we've been so aggressive in the US, is the concern that where we are is on the cusp of a pandemic. We're gonna hope that we're not gonna have a pandemic, but the aggressive stance that you've seen in the US is us preparing as if we might. And that means that we need to do a lot of measures at our healthcare level and in the public to prepare for it.
And really that's the challenge. You know, healthcare personnel have so many other more urgent things that they're dealing with on a day-to-day basis. And the people that, you know, fund healthcare, the C-suite, or the people that are deciding where the money goes, you can imagine how difficult it is for them to make the decision to put a lot of resources or finances into coronavirus preparation because there are so many other things that are on the plate that everybody's trying to deal with. So it's this constant tension and constant balancing act that goes on. So I think for people like myself, other infection preventionists on the front lines, is trying, you know, to message to people that, look, if you do so many of these things, you'll be protecting yourself no matter what comes along. You know, whether coronavirus really starts to escalate here, or whether it's the next novel thing, or whether it's, you know, chicken pox, or whatever it might be, if you can do the basic infection prevention things that I know I tell you we should do it all the time, but I really mean it, and this is why I mean it. And so I do think if you take it as an opportunity to remind people, hopefully the message, you know, resonates. But again, if this goes on in China for, you know, a long time and still doesn't come to the States, it becomes harder and harder to keep their attention. And then the next shiny object, you know, will be what everybody's looking at. So I do think it's an ongoing challenge, but it's never a bad idea to keep reminding people of the basics that do not change. A lot of things did change with SARS. A lot of things, I mentioned HIV before. So some things do change, but certain basic things never change. And so you can never go wrong if you continue to remind people about that. And I'd be interested what your thoughts are, Amanda.
Maybe just to come from the community side a little bit. I think for me, epidemics are a health issue, a political issue, and a social issue. And I think we can try to look at the science and how the virus will behave and how the transmission will occur. But I've been in a number of outbreaks where I thought we were never going to get on top of it, and the community has come together and we've put the right interventions in place, and the outbreak is finished. I've deployed whole hospitals for 3 cases of monkeypox and arrived and it was over, and the next time I didn't deploy anything and 150 cases exploded. So the science and the transmission is extremely important, and the medical countermeasures and what we do in hospitals. But the way we communicate this will affect where we are in the outbreak. The way that communities respond to the fear and the potential for the outbreak will also affect how the transmission occurs. And then the politics. And unfortunately, not all politics everywhere is driven by good science. And so making sure that we have enough resources early enough to respond. One of our biggest fears is often that in 6 months' time it will look like we cried wolf, that we look like we said the sky is falling and the outbreak didn't turn into a pandemic. but we never have enough resources until the epidemic's going down. So you always look like you've asked for too much, because as soon as you have what you need, the cases go down. And we've been caught short in international responses several times where we've got enough resources and then someone's like, oh, the cases are going down. As soon as you remove those resources, the cases go back up. So it is difficult, and it's important that the media help us communicate that as soon as we have enough in place, as the aggressive measures start to work, if we remove those, the cases change. And so, understanding that there's a lot of different factors that drive transmission, and to some extent, in the US, the health and the science plays a bigger role in some of the areas that we play. The community and resources play a bigger role in terms of where we will be.
And fear is truly infectious because you see it so clearly. As soon as people get afraid, it's the first thing that spreads like wildfire.
Yeah, I think one of the things about this pathogen that's different, people ask me to compare this novel coronavirus with influenza, for example. But with influenza, we have vaccines, we have antivirals, and we know how they work, and we know the seasonality. And as bad as the flu season might be now, at least we have some tools that we can use. The problem with this novel coronavirus is folks are rushing really quickly to get vaccines, but vaccine development takes a while. And we're probably talking a year. Our clinical experts are looking at what products might be helpful in the group of products that are out there, but there's not something far down the line that's specifically targeted for this. And so what we're left with is some old-fashioned tools that sound a little mundane, but it's containment and mitigation and basically keeping people who are sick from passing it on. And that seems trite to people, that things like, don't go out, don't go to work when you're sick, right? I mean, how many times have we all said that? But it's difficult for people to stay home. Not everybody can do it. Not every business is at work. Kids aren't supposed to go to school sick, but we all know, we all have probably been guilty of sending our kids to school a couple times with a runny nose. But those are the kind of measures that we're going to need the community to come together around if this indeed continues to spread, because those are the best tools we have. Social distancing is what could contain this if it continues to progress here.
And I just want to build on that to say, essentially in these outbreaks, and I'm slightly biased, but the media has just a bigger role to play as our scientists, because we need to engage and communicate with the communities effectively. We need to raise the risk and the awareness without creating fear, and it's a difficult balance. But these control measures are extremely important, and it was very similar in Ebola. You can stop Ebola very simply if people follow the rules. And we've seen in DRC, despite having a vaccine and a countermeasure, we haven't been able to control it because we haven't been able to engage the community effectively and have them participate. And these types of outbreaks, the way the media communicates, how we're able to control the misinformation, how we're able to change the way society engages and moves and responds to the virus, has a substantial role in terms of how we're able to control it.
Thank you. I think we'll open it up for questions in a second if people want to think about anything they want to ask. I have just one last one to pivot off of what Dr. Messonnier was saying about a vaccine. There are no vaccines or proven treatments for the coronavirus yet. Can you talk about why vaccines in particular are so hard to research and test?
Yeah, I think it's, vaccines are the one thing that we give people when they're well, and it's not like a therapy, right? You have to make sure that you're testing it sufficiently, and so Dr. Fauci has actually talked about that in 3 months, which is really moving quickly. He thinks that they'll have a vaccine in phase 1 trials, but you have to go through a lot of research studies before you start putting vaccines in people's arm. We need to make sure that they're safe, and they have to start in small numbers and then work their way up to big numbers. We wouldn't want something inadvertent to happen, and we need to prove that they're effective, and that just takes a while. I mean, again, a year is actually rocket speed, and the Ebola vaccine we got it so quickly, partly because scientists had already been working on it when the Ebola outbreak happened, so they weren't starting from scratch. For this novel coronavirus, there has been some work, especially on MERS vaccines. There has been some development work to build off of it, but it's starting pretty early.
And just one last sort of jargon check before we move on. Phase 1 is?
Phase 1 is the earliest possible studies, right? So it goes phase 1, phase 2, phase 3, and it just increases in size and complexity and people. You don't want to give a vaccine to lots of people until you prove in a few people that it's safe and that it at least mounts some kind of immune response that would suggest that it would be effective. And so it scales up.
Any questions in the audience? Wait for a mic, and then if you could identify yourself before you ask your question.
Thank you. Oscar Allen Nacho. Hopefully an easier question than polymerase chain reaction. Could you describe the difference between someone that's asymptomatic and an asymptomatic carrier?
Yeah. I think these terms are being probably bandied around a lot, right? I mean, I'm asymptomatic, right? I don't have the disease. An asymptomatic carrier, the question is, there are other diseases where somebody carries the pathogen in their nose and doesn't have illness from it. In some cases, somebody never gets illness from it, but they can still pass it along. In other cases, they're asymptomatic carrier because in a day or two, they're going to be sick, and they haven't gotten sick yet. And so the question with this illness is, there have been some reports that people have gotten sick and that they caught it from somebody who themselves didn't have symptoms, but actually was shown to have the disease. However, in a couple of those cases, when people have gone back and looked, that initial person who was supposedly asymptomatic actually did have mild illness. And yes. And we know from, especially from MERS, where we've done a lot more research, that there have also been reports of people who were asymptomatic seroconverters. So they reportedly didn't have symptoms, but when we draw their blood, we can actually show that they had an antibody response, which means that they've been exposed. However, when somebody went back and much more in a detailed fashion asked them, and a lot of these patients are actually able to find that they did have some kind of mild symptoms. But truth is, I don't know about how busy y'all have been for the past couple weeks, but if you asked me if I had a sore throat 2 weeks ago, I might not remember. And so there's a question for some of these patients. And once, a year from now when all is said and done, will we really be certain that there are asymptomatic people who are passing it? Or were they people who had mild symptoms? And, most people in most diseases, generally, it is people who are more symptomatic that are more likely to pass it along, even if people who are mildly symptomatic can still transmit.
Sorry, go ahead, David, then Jeannie. Yeah. No, it's okay. Oh, I saw David, then Jeannie.
Hi, David Lim with Politico. The CDC last week said that you started shipping out those diagnostic tests. I wanted to ask the public health labs through the IRR, how many have ordered the test, have the kits in place, and how many have completed validation at this stage?
I can't answer that concretely. I can say that we've shipped to all 50 states as well as multiple countries. It's 30-something countries. And I know that most of the states have received it. I have to say, this is definitely, things are moving really fast. And there were, for example, a couple of shipping errors where things didn't get where they were supposed to on the day that they were supposed to. 3 boxes got shipped, and 1 box got there, and the others 2 didn't. I won't tell you what shipping company it was. So there have been a couple of those issues. And the states are still standing up the tasks. So I know that as of this morning, at least one of those labs was already using it, but I think a lot of them are working through their own validation. Just like CDC, nobody wants to be mistaken and inadvertently tell someone that they're positive or negative. And so, we want to make sure that we give them time to complete their own validations before they start testing.
And to be sure, at this point, there hasn't been some sort of massive influx of need for the labs to be testing?
Well, I guess it depends on your perspective, right? If you're a patient in California, you would much rather have the test done locally than having to wait for the samples to get here because it takes an extra day or two.
Well, I guess my question is, I mean, is there a really large influx of people needing to be tested at this point?
That's a great point. We call this PUI. It's a jargony word also. It's called patients under investigation, and it's the word that we have sort of come to use, the phrase that we've come to use to explain people that aren't cases because they don't have this novel coronavirus, but either they meet a general definition of somebody who's ill and has a travel history that would make them suspicious. And so the number of people we want to be bigger because we want clinicians to have a low, we want them to be suspicious of people who have recently traveled to Wuhan and have a fever and respiratory illness. So that number is the PUI number, and there's I don't know, in the last several hundred people in that category where there is a test somewhere being done. Some of those people probably we have a low index of suspicion, but we have a team of people at CDC 24/7 taking those phone calls from health departments, and if somebody thinks that it's possible, we test.
Jeannie?
Hi, Jeannie Bauman with Bloomberg Law. I was hoping you could, I was wondering if you've been able to get samples of the virus from patients and what you can do with what you need those samples for versus what you can do with the genetic sequence. And also, I mean, does it matter that if you haven't been able to get samples from China, like is that important as well?
Okay, so the genetic sequence is great, and the genetic sequence was enough for us to be able to develop this diagnostic test. However, once we started having cases in the US, we also had able to grow virus. So the virus is at something called NIH's BEI repository resource. And if you ask me what BEI stands for, I'm sorry, I don't know. I don't remember. But it's a NIH resource where we basically put the virus there so that other scientists around the country can get access to it. And other scientists are going to use it for things like development of other diagnostic tests, which is great. We want lots of people using it. There's also research studies that are going to be done with that virus. In addition, we are developing a serological assay. So a serology is a way that you tell if somebody has developed antibodies to the pathogen. It might be that somebody got sick, got better, and we missed the part where they were sick, and a serology will really help us be able to do that. So having the sequence is great. Having the strain is important for our laboratorians and scientists as well as scientists around the country. Because China and multiple other countries now post their sequences, which again is really different than how the world was 10 years ago, our scientists and scientists around the world are able to compare the genetic coding of their strains versus our strains. It's comforting that there are not a lot of differences. This is a pathogen that morphs a lot, so they're actually really similar. Would it be great if we had strains, virus itself from lots of places? Sure, but what we have is actually, we're able to do most of what we need with what we have here.
I'm Patricia with Military Times. I'm just curious as to how many people are currently under quarantine, federal quarantine right now, if we have that number. And also the first group is supposed to be getting out tomorrow, so I just wanted to confirm that they indeed will be leaving March Air Force Base tomorrow.
So there were somewhere around 800-ish people under federal quarantine. I'm sorry, I don't have that number more precisely. Most of those people came in 5 flights of people who were evacuated from Wuhan. I think that is both because of the rates of disease there, but also because of all the chaos in the city. Services have really broken down, healthcare access. So I think those people were quite happy to be home, but they are under federal quarantine. And as you say, the first group of those people who are at March Air Force Base are scheduled to come off of their 14-day quarantine tomorrow. We're already working, or they're already working with ACF, Association for Children and Families, to help them figure out how to get home. So they will hopefully be happily leaving on their way to rejoin their families tomorrow.
Hi, Peter Lovenheim with the Rochester, New York Beacon. Just to try to get some perspective, I think the number I heard is there's maybe 40,000 cases of this in China. But how many cases of regular flu are there in China at the same time?
I can't answer that for China. I can tell you in the U.S., there are 24 million cases of flu this flu season, and 12,000 deaths and somewhere around 78 deaths in kids.
Okay, but you don't have any comparable figure in.
I don't have it off the top of the head, but the number's out there somewhere. You know, in fact, we work closely with China, and we have for many years around influenza and their influenza surveillance. But I don't have the number off the top of my head.
Thanks.
And I think
Hi, Marisa with Axios. I have a question for Anne-Marie. You emphasized a lot on communication and planning in place for that. Where does data sharing go into that, and like how can we incentivize hospitals to provide more information when it comes to medical supplies, staffing, and especially if this potentially gets bigger or even in your past experience?
That's a great question. When I mentioned communication, I really was referring to the fact that we need to figure out where we're at with our supply chain. In other words, our manufacturers that are getting us the supplies that we need. But in terms of incentivizing hospitals to report, do you mean, because we in our area have had no coronavirus at all. We have had some people tested because they've come back from mainland China. To this point, none of them have been positive. Are you talking about the data in terms of how many supplies we have? Or are you talking about the actual number of people infected? Or are you talking about all of it?
Kind of all of it. I mean, there's so many moving parts to, you know, in terms of hospitals within federal and state and health, and like how does a hospital, you know, like from your perspective, like what does that look like?
Well, you know, there are certain things that are mandatorily reported by CMS, for instance, and then there are things that are specific to each state. They could be surgical wound infections, things like that. So again, we are under mandates, both federally as well as statewide. And then if there's an outbreak situation, and by outbreak, that would be defined as a number of cases that's more than normal. So I'll use norovirus as an example, which is the cruise ship virus that you often hear about. Certainly we see outbreaks of that in our facilities, whether it be nursing homes or hospitals. Any outbreak is reportable to the public health department. So if you know you're seeing something above your normal, by law, I'm supposed to report that to the health department. So I do think there's already requirements in place. Now in terms of supplies, I know right before I left, New York State just sent out some information that they're asking every hospital to submit what they call a HERDS report. Again, I can't remember what HERDS stands for, and they're asking us, okay, where are you at with supplies? So we are having to report that to them. Now that happens to be New York State. So again, some of this is federally required, some of it is state required. So I don't know if that helps, but those are some of the things that we already do and would continue to do.
any more questions in the audience? I see one in the back.
Well, I'm walking over there. I'm going to ask a question too. This is Julie Moose. I'm executive director of the National Press Club Journalism Institute. And I wonder if you could talk about some of the most dangerous misinformation that's been floating around about this.
Okay. I just wanted to start that one because one of the asks I have for all of you is that one of the things I'm struggling with my healthcare workers is they see images, whether it be on the nightly news or in newspapers or so forth. For instance, the patient in Illinois where there was, they were being cared for by a robot. And then they see pictures of people in hazmat suits. And things like that, and they're saying to me, but wait, you just told us we shouldn't panic, and if I wear an N95 mask that's been fit tested, you know, and do the other things that you're telling us to do, we'll be fine. And so there's this dissonance that happens, and so I don't know whether Nancy can help with that as well, but that is a challenge for us. And you know, I remember during SARS and I remember during Ebola where I had a lot of staff members say to me, you know what, if Ebola comes to our facility, I'm not coming to work. And, you know, we talked about that with HR and we had plans in place if that had happened, but those are the things that, you know, for healthcare providers who have families and loved ones and you know, so they're fearful. And so this dissonance, I think, is, for me, one of the biggest challenges that I face.
Amanda, do you?
To be honest, I think at the moment misinformation is probably at a lower level than I've seen in a lot of the other. I think the media has done a fantastic job at trying to answer the core questions and explain. I've been impressed. This is one of the first times I've been in a developed country during an outbreak. Normally I'm somewhere else. So I've been relatively impressed. There is a really good link on the WHO website called Mythbusters, and they're making nice infographics about some of those things, about whether it was because Chinese people ate dogs or, you know, some of these. But I haven't really seen any takeoff at scale yet. I'm sure inside China, you know, there's been some reports about the WeChat and censorship there. I think the scariest one for me at the moment is the normalization of the risk. It's only, I use my family, my grandmother, as a test for this, and the family from Australia on the weekend was like, oh well, I was too busy to answer a call on the weekend, and I said I was busy, and they're like, oh, it's just going to be like the flu. I think that's going to be our biggest issue with misinformation. And then the conspiracy theories are always difficult to overcome. The biggest one will be if we get a vaccine, and vaccine hesitancy is a major issue for us. And I think, you know, I was in a meeting at a global level about vaccine, and a doctor said to me, I don't know why you worry so much. Once we get a vaccine, it'll be fine. And I was like, well, getting vaccine into people is actually sometimes as big a challenge as making the vaccine. So I've been impressed with the reporting so far. I've seen really responsible reactions to some of the initial misinformation, but it is a major threat for all epidemics, and particularly this one that we have to be vigilant on. And so there's whole teams now in almost all the ministries of health, specifically for risk communication, focused on misinformation.
So I want to bring up another one, and that is masks, because being from New York, a friend of mine, a colleague, her son lives in New York City, and she told me, and again, I am not in New York City, so I can't swear to this, but I'm being told that many people in the subways of New York City are wearing masks. And we already know that we could face a shortage of necessary supplies. And so anything we can do to get that message out is that, number one, there's no need to be wearing masks right now. Number two, it gives people a false sense of security, because then are they going to forget about hand hygiene? And granted, it might stop them from putting their, you know, picking their nose or putting their finger in their mouth, but it won't stop them from rubbing their eyes and so forth. And so the whole idea of disinfection of surfaces and hand hygiene and running out of necessary supplies. I was coming home from San Antonio a couple weeks ago, and I saw probably 10% of people in the airport wearing masks. Now, maybe it was because of regular flu, I don't know, but I don't think so. I think it was coronavirus. So I think the more we can get the word out that it's not at the point of having to wear masks for this, I think it's an important message.
Yeah, what I would say is that, you know, I think the media reporting has been solid, and I mean, we've been proactive, and I think our partners in the media have been receptive. Where I worry more is in social media, where things can spread like wildfire. And on a good side, I would say that Facebook, Twitter, Pinterest, we've been working with those groups for years actually around vaccine hesitancy, and they've been very receptive to at least trying to make sure that the top line of where their messaging is sends people to more scientifically curated, credible information. And I think that's a huge improvement on where things were a couple years ago. But it doesn't stymie all the other conversation. And there have been, myths out there about things like treatment, and I do worry about that. I guess the other thing I worry about is the stigma. It's definitely been an important message to point out that this outbreak is mostly in China, and that's where the risk is. But there are a huge number of Chinese Americans here in the United States who have nothing to do with this outbreak and are not at risk. And we worry about that, pointing out where the outbreak's coming from, stigmatizing others. And finally, I agree about this precipice that we're on. We want people to be aware. We want them to start thinking about this with us, but we don't want them to be overly concerned as yet. And it's hard to walk that line with people. If you tell them that you're concerned, people want to know what you want them to do. And if the answer is just wait, I mean, that's not very satisfying. So when we try to give the public messages, it's usually because there's and then you should do something. And in fact, there's not really something in general that the general public can be doing right now, except staying alert and washing their hands and covering their cough. And we've been saying those things to people every year at this time of year because it's flu season, and it sometimes falls on deaf ears. So I do think that we're at a difficult precipice where we want the public to understand, but we want them to sort of wait with us, and that's a hard message to get across.
And I hope I didn't
Okay,
mean to imply that there's misinformation that you're spreading at all. And I agree that it's been handled very well. I'm just asking for additional help is all. I'm not saying that what's been done so far has not been appropriate. It's just, I think we all have to work together to do an even better job, I think.
I'm Joyce Johnson. I have two quick questions. One is, what is the case fatality rate in China as well as in other places? And the second thing is if a family, if a member of a household developed disease, how should they be taken care of by the other family members so as not to spread disease in the household?
So the first question, I have refrained from saying case fatality ratio because there are 40,000 cases and 900 deaths. You could divide that, except nobody's completely sure if that 40,000 is the full extent of all the cases. And there's a couple reasons. One is early on in the outbreak, we think that the Chinese government's case definition really focused on pneumonia, and so they might have not detected the milder illness. We also know from previous outbreaks that in general, patients who are more severe tended to be detected sooner, and therefore the case fatality rate kind of evens out later. In general, it seems like it's around 2%, but again, I worry that that at the end we may find that that's different. And in terms of what somebody should do in a family, I think it's hard to make that judgment as a universal, because in Wuhan right now, with those incredibly high attack rates, the decision may be different than it is in the United States. Similarly, if you're parents and you've been taking care of your sick child for a couple days, or a sick grandmother, you may have already been exposed. And so I really think right now in the US, there are so few cases that we, working with local and state health departments, are having individualized guidance for each case in terms of where that person should be, how they should be treated. And we're also being aggressive at investigating all these cases, all 12 of them, because everything we learn about each case will help us with the subsequent cases. So I hate to give you a universal answer to that question. I think it's more that we have 800 people at CDC working on this outbreak right now, a couple hundred in the field, working with the state and local health departments at airports, on the military bases, the rest in Atlanta. And a lot of what they're doing is trying to take all this data that we have and synthesize it so that the guidance continues to improve.
Any other audience questions?
Oops,
I see a couple on this side. And Julie, how are we on time?
Hi, I'm Shannon from MedPage Today. I wanted to ask a little bit about supply chain concerns. You mentioned the fear of the masks being depleted. Since a lot of PPE does come from China, are there measures that the U.S. could take? Are there redundancies that we could start thinking about? Or is that not really, what's the risk right now of a supply disruption?
I'll start it off. One of the good things about Ebola was that we all, with emergency preparedness, had to stockpile. So we all have supplies in stockpiles that, so we're checking those right now to make sure they're still intact, and getting those numbers as well as looking at our supply chain. For instance, Cardinal just had to recall thousands and thousands of gowns because of a lack of sterility and lack of quality control. And so infection preventionists all around the country have been discussing that. Now, I went right back to my supply chain, and fortunately, we don't get ours from Cardinal, so we had no issue. So we're not experiencing a challenge with gowns right now. On the other hand, there's other infection preventionists that I've talked to around the country that are concerned about that. And so it really, it just depends on where you're at in the country right now and who your supply chain is coming from. You might want to add.
Yeah, I would just say that the World Health Organization actually announced last week a concern about the global supply of PPE. And so I think we need to put this in context that it's something we're all concerned about. The hard part about this is to know how much PPE you're going to need. You need to know how long this is going to last and how big it's going to get. So we do have, and there's like 50 separate modelers working with us at CDC trying to model the available data to make those kind of projections to sort of see how long this is going to last, which it directly relates to how long our supply will last. But given the place where we are, which is the concern that we all have that this may go on for a while, it is the right time to start thinking about how we're using our available supplies. CDC, we just updated our information on our website at the end of last week, and it has specific infection control information. It's vitally important that our healthcare providers feel safe when they're taking care of patients because, of course, they're essential to the clinical care of the patient. There's also sort of the notion of source control. I mean, what you really want to do is put the mask on the patient, right? Because if the mask is on the patient, then everybody's protected more than putting a mask on 10 different people. So our measures we are asking healthcare providers and state health departments and health organizations to work with us at this juncture, and we're working with all the alphabet of all the organizations that help hospitals and healthcare organizations make their rules. But we think it is the right time to make sure that we're using it appropriately, but we're also conserving it under the hope, under the possibility that we may need it later.
I just want to add the international context to that because one of the things that happened in Ebola was once there was a case here in America, all of the supply shifted from West Africa to developed countries, and we didn't have any supply for where we were treating patients that actually had Ebola. So the part of the WHO's approach, and there was a lot of work done after Ebola, is about the equitable distribution of available PPE and making sure we have it where the virus is and where we're getting transmission. And so it is important, that we make sure that we've got enough supply, and CDC are excellent at trying to find that balance. But we are getting calls from the Gambia, for example. They called me yesterday. They have 2 million people, but they rely on tourism. They're extremely worried about what the virus will do to their economy, and they have very limited PPE supply. So it's a global issue that we're looking at and making sure that the countries that are having cases have access is extremely important as well.
We have a question from the live stream from Carrie. Is there a concern about ordering anything, household items and goods, that is shipped directly from China?
Yeah,
Yeah, I've gotten asked this a lot. So we don't have data yet on this novel coronavirus because it's been like 6 weeks, right, since we've identified it. The closest data we have is from MERS and SARS, where we've looked to see its survivability on surface. And in general, on sort of generic surfaces, in ambient temperatures, it doesn't survive so long. So we've sort of figured out how long does it take to ship a package from China to the United States, which is mostly what people are asking about. And on the kind of surfaces that would be shipped from China to the United States, it shouldn't survive long. And therefore, we don't think that it's a risk to anybody who's receiving goods from China.
So you're saying that I'm sorry, Catherine Fox Holland, freelance reporter. You're saying that services are breaking down in Wuhan just because of the controls. Are we or somebody looking at basically whether they made the right decision, given that there's a risk either way you go, and is this the biggest quarantine that anybody has ever done in the history of the world? So we have to look at it carefully to see what works and what doesn't.
Yeah, I do think that in modern times it's an unprecedented step, but it was also an unprecedented situation where that they were faced with. I think there'll be lots of time when this is all over for people to second guess what China did, as well as I'm sure people will second guess what CDC did. But right now, we're looking forward and focusing on what we need to do next. And, I think there will be time.
I'm not asking whether they did the right thing or not. I'm asking, is somebody on the ground studying that now?
Is somebody on the ground in Wuhan studying whether they did the right thing?
Yeah, I mean, and we seem to know that certain things are breaking down. Do we have enough people there studying everything that's happening?
Yeah, so I thought this, but maybe this is not so visible, but CDC has staff in Beijing. We've had them there for a long time, working closely with the Chinese government on a variety of issues, including influenza. However, we have not been invited to come directly participate in this investigation, so we don't have staff in Wuhan working on that. I presume, there are many competent scientists within China, and I would hope that somebody is looking at that, but it's not data that we have direct information on, nor studies that we've been directly involved in.
Amanda, did you have something to say on that?
No.
All right, do we have time for any more?
Thank you.
Well, if there are no more questions from the audience, I just want to invite our panelists to, if they have any, anything else they want to say about what reporters listening today should take away in terms of their outbreak coverage in general and the, coronavirus coverage specifically.
Yeah, I guess my advice is there's a lot that we don't know about this, and this is one of them. This is the difficult type of outbreak for us to manage because communication is so important, and making sure that we're keeping the public up to date with the information that we have. We had experience in Zika where we gave information and we learnt later that not all of that was right, and how we update that. And so the media plays a key role in helping us with that key piece. My one concern is there's going to be a lull between what we've all said now, we're running out of things to say, until we find out more details or there's another outbreak, the outbreak spreads. And in that lull, I tend to find we get a bit sensationalist and we look for lots of different angles, or we start nitpicking or looking back, and try to resist that because we're doing the best we can with the information that we have going forward, and there'll be time to look back and to review. But I guess, it happened a lot to me in Ebola. There was kind of this lull where people were just getting sick and there was nothing sensational to say, and then all these, different angles started to come out, got very difficult to manage, and people were looking for, more sensational kind of items to write about. And so my ask is, I guess, stay with us. This is hard to communicate. We do need the media. They're going to play a vital role in how we're able to manage this and to make sure that the community stays informed. And I guess, at least from my side, but I think a number of the big organizations have done a great job at being transparent and sharing the information as we get it, and that we commit to kind of continuing to do that.
And just kudos. I mean, this is such a great first step in terms of you're all here and you put this together, and I'm just very grateful. And it does make somebody like myself feel like we are all going to be working together on this. So I just really appreciate it, and thank you.
I certainly appreciate the opportunity to be here today. I have been doing a lot of media the past month, but you know, y'all ask us good questions and keep us honest with those questions. And I mean, I want you to know that, I mean, I don't love it every day, but you know, you guys are a vital part of the equation to get the right information to the public, and it's important that the public hears credible scientific information. It has been moving really quickly from our perspective. I mean, since the end of December till now, I don't think things have slowed down for 1 minute. And pretty much every day there's something happening that requires us to rethink some part of what we thought we knew. It's not the most comfortable situation to be in. We'd rather be in situations where we fully understand the science and the pathogen and can make every decision based on really deep science and lots of time to mull it over. And we find ourselves having to make decisions rapidly with insufficient information and the knowledge that there is going to be something, at least something that we were wrong about. And so I guess I would appreciate your patience and your understanding, because you know, the only other way to do things would be not to make recommendations or decisions, and we can't do that. And so, you know, we expect that there's gonna be some part of this that we weren't right about, but at the time, scientifically at CDC, you have a bunch of really credible, competent experts who were sitting around a table making the best assessment they could of the data. People that I work with at CDC are an incredibly dedicated group of people, but it's led by scientists who have been doing this for a long time and found themselves in an unprecedented situation and took actions that are different than we've taken in Zika or Ebola or all the other crises we've been through. And you know, I'm proud to represent them, but also proud that when we have those discussions, it's with people that really know their science and know the impact of the recommendations that we're making.
Well, please join me in thanking Amanda McClelland, Anne-Marie Pittis, and Dr. Nancy Messonnier for sharing their wisdom with us today.
Also, we want to thank Andrew, and thank you to Rachel for pulling this together. And before everybody gets up, I want to mention two other things. One is many of you here have an explicit interest in policy and also probably sometimes cover health policy, education policy, other things. We have a program coming up on how to report and write policy that the public will actually read and use. And I would encourage you, any of your employers are actually have given us early feedback that indicates they want to send folks to this program. So if you're interested, it's February 28th. It's going to be a half-day workshop with Sarah Cliff from New York Times and Ben Weider from McClatchy on when and how to humanize policy stories, finding and interpreting data that's reliable, and how to write policies for the general public, even if you already write for insiders or for outsiders who want to be insiders. So if you're interested, go to pressclubinstitute.org, click on programs. You'll find lots of information about that and other programs. The other thing is I want to talk about somebody who's not in the room. You'll see many of us wearing pins that say Free Austin Tice. Austin is the only American journalist who is being held abroad. He was detained in Syria 2,737 days ago. It's about 7.5 years now. And he was there reporting on the conflict for McClatchy and the Washington Post. The U.S. government believes Austin is alive and is working very hard to bring Austin home. We've been working with his family as well, and we stand with them. We hope that you will too. The club has just announced its second night out for Austin, which will be April 29th. Restaurants around the country and here in DC and Maryland and Virginia will donate a portion of their proceeds to supplement the FBI reward for information leading to Austin's safe return. So you can go out that night and find lots of other ways to support Austin as well. Just go to nightoutforaustin.com. Thank you for supporting him. Thank you for supporting this program tonight. And thank you guys again for coming.
Thank you.